Hello, and welcome to the ACR Journals on Air podcast. I am your host, Vicky Shanmugam. We've known for years that glucocorticoids are bad for the bones and are the most common cause of secondary osteoporosis. However, inflammatory diseases are also a cause of loss of bone mineral density. So is there ever a reasonable trade-off where low doses of glucocorticoids reduce the inflammatory burden and thereby reduce fracture risk? The manuscript we will discuss today is Bone Loss in Inflammatory Rheumatic Muscular Disease Patients Treated with Low-Dose Glucocorticoids and Prevention by Anti-Osteoporosis Medications. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I'm happy to be joined by the manuscript's first author, Dr. Giovanni Adami. Dr. Adami is a rheumatologist at the Rheumatology Unit of the University of Verona. He holds both a medical degree and a PhD, and his PhD position is in clinical and experimental biomedical sciences at the School of Life and Health Sciences at the University of Verona. He completed a postdoctoral fellowship at the Division of Clinical Immunology and Rheumatology at the University of Alabama in Birmingham. Welcome to the show, Giovanni.
Welcome, everybody, and thanks for having me.
So I wanted to start our discussion today with a big why. Why did you do this study? Don't we know that glucocorticoids are bad for the bones?
Well, we certainly know that glucocorticoids are bad to the bone at a certain dosage. So basically from 1950s, when the Philip Henge discovered the glucocorticoids, we know that high-dose glucocorticoids are bad for the bone. But in the last, I would say, 5 years, many publications came out saying that might be that low-dose glucocorticoids in inflammatory diseases might be even beneficial. We had this large randomized controlled trial, the Gloria trial, showing that 5 milligrams of prednisone might be beneficial. And the trade-off is very, very low, very few adverse events, very few side effects, which might be argued by some experts, but still there's some debate. So that's exactly the reason for us to do the study.
And can you explain why bone mineral density measurement using dual X-ray absorptiometry or DEXA is sometimes misleading in patients with glucocorticoid-induced osteoporosis?
Well, this is a very good question because, for example, the Gloria trial explored the BMD. And we also know, as you stated, that the DXA, the BMD, bone mineral density, might be misleading because glucocorticoids also affect the microarchitecture of the bone. So one of the effects of glucocorticoids is to kill osteoblasts and to kill osteocytes. So you don't always lose your bone density. So it might be a very normal BMD, while your HISC it's raised up and goes up dramatically in some cases. That's especially true in the long term, when the glucocorticoids-induced osteoporosis is mainly a low bone turnover osteoporosis. So you have very few cells performing in the bones. So you have osteoclast reduced, osteoblast reduced. That leads to a low bone turnover state and is not adequately captured by DEXA.
Yeah, and so tell us a little bit about this derived fracture risk assessment tool, or I think you would call it DFRA. What is it? What is the DFRA database? Who is enrolled? And what data is available in this data set? How is it collected? People in the US and UK are probably more familiar with FRAX. Mm-hmm. So can you explain how DFRA differs from the other fracture risk assessment scores?
Absolutely. The DFRA was developed in 2010, so 2 years after the FRAX, and basically is derived from the FRAX. So that's why it derived. The derived fracture risk assessment is very, very similar to FRAX. It incorporates the very similar fracture risk factors, and that has been refined on the Italian population. So basically, it was tailored on the Italian population. It was also finely tuned contrast to the FRAX on certain risk factors. For example, glucocorticoids. In the FRAX, the glucocorticoids is considered as a dichotomous variable. So you have yes or no. You can adjust for that in the later version of the FRAX. But the DEFRA was originally developed on a semi-quantitative scale. So basically, you can choose on different thresholds of glucocorticoids. You have a little bit more rheumatic musculoskeletal diseases, inflammatory rheumatic and musculoskeletal diseases, under comorbidities included. Just a very few more. You have the lumbar spine BMD. So it's very similar, but it might be more detailed, I would say. And it collects patients from Italy. So basically, if you are a bone specialist or primary care physician in Italy, you can include your patient in the data set and have your DEFRA calculated. So your risk of fracture, 10-year risk of fractures calculated for free. And at the same time, you can include the patient into the data sets. So that's exactly how we collected the data from physicians all over Italy, more than 2,000 physicians collecting the data and registered to the DEFRA dataset.
How does one apply to do research using the DEFRA dataset? Does one have to be Italian?
Well, not exactly. No, absolutely. The DEFRA dataset is owned by the University of Verona. So basically, it has been registered at the University of Verona, where I work in. But on an application, basically asking us for doing some research, we are really open to do that.
And so how did you set up this particular study? Can you describe for our listeners the cohorts and how you matched them, as well as how you categorize them by glucocorticoid exposure?
Yeah, absolutely. Well, basically, we did a longitudinal study on patients that had 2 visits or at least 2 visits into the DEFRA. So basically, we have patients with more than 2, 3, 4 visits. And this was a cohort study. And we also had many patients with inflammatory rheumatic and musculoskeletal diseases, but also a control patient with just postmenopausal osteoporosis or just other types of diseases without glucocorticoid intake. And we then look at the data and do a propensity score matching and matched all the patients with glucocorticoid exposure with an inflammatory rheumatic musculoskeletal diseases and to control. And to based on the propensity score matching was based on fracture risk, on bone mineral density, age, other variables that are risk factor for fracture. So basically, we wanna isolate the effect of glucocorticoids and rheumatic musculoskeletal diseases on fracture risk.
And just so I am sure I understand, do you then exclude any patients who are using glucocorticoids for other reasons? So do you exclude diseases that might otherwise impact bone density, like inflammatory bowel diseases?
Yeah, we did that. We have other diseases that might require glucocorticoid. So basically, inflammatory bowel diseases, probably the most common other than IRMD, but also multiple sclerosis or other diseases that were not recorded in the data sets, like other glucocorticoid requiring diseases. So yeah, we did that. Now that you mentioned, we might do in the future another analysis on those patients.
Well, I was thinking that too, that it might be useful to know. So can you give our listeners a little bit more detail on the characteristics of the cohorts? Which rheumatic diseases were represented in the rheumatic disease cohort?
Yeah, absolutely. Basically, the large majority was rheumatoid arthritis. Well, there are many studies showing that rheumatoid arthritis is the most common glucocorticoid requiring diseases. And despite we have a lot of other medications to taper the glucocorticoid dose, we still use it a lot. Then we have a few patients with psoriatic arthritis, SLE, systemic sclerosis, just a minor proportion of them. And then in the other patient were with vasculitis or polymyalgia rheumatica and so on. But I would say that more than 50%, especially those who were taking higher doses, have rheumatoid arthritis.
And do you have demographic details that you can share of the cohorts?
Well, yeah. Basically, they were all female because the death rate set in that way was designed for women. That's probably the greatest limitation in the study.
Mhm.
And patients were all about 50 years of age. So mainly postmenopausal women. So the average age was around 67, very similar for patient receiving various dose, so even low dose or high dose. So older postmenopausal women. This is clearly a limitation, but also probably a strength. Those are the patient that you care more about their bones. So
Mhm. Or that's when we start caring about the bones. We probably should care a little earlier in life, right?
probably, yeah.
So let's talk about your terrific graphs. I think it's figure 1 that has the beautiful rainbow dot plot looking at baseline and then the follow-up T-scores from the patients on the various doses of glucocorticoids compared to controls. And you looked at this in 2 groups, those who were receiving therapy for osteoporosis and those who were not receiving therapy. Can you turn those images into words and tell our listeners what they show?
Yeah, absolutely. Basically, we did first stratify the population based on glucocorticoid intake. So you can see doses above 5 milligrams, those you should care more because there are plenty of data showing that this dramatically affects bone density and also fracture risk, but also those with very low dose, less than 5 to 2.5 and less than 2.5. So minimal doses, those are the patient that we care less probably. And you can see that in the no anti-osteoporosis treatment picture, the above panel, well, there is the effects in patients that are not receiving anything else than glucocorticoids. So basically, they were just neglected by the physician, probably. I shouldn't say that, but they weren't receiving bisphosphonate or anything, just vitamin D. In large proportion were receiving vitamin D. And you can see that the bone loss is quite significant and also meaningful from a clinical point of view. So losing 4% of bone mineral density in 2 years is approximately related to a 30 to 40% higher risk in fracture that has been largely demonstrated in other studies. And below that, you can see the effects of glucocorticoids combined with an antiosteoporotic treatment. So you would expect that the bone loss should be stopped. And this is absolutely true. You can halt and even reverse bone loss in patients receiving very low dose of glucocorticoids. But in patients receiving higher doses, more than 5 milligrams per day, well, in those patients, you can just really reduce the bone loss and not stopping. So that's the first message. Well, bisphosphonates, those patients were mainly 90% of patients in bisphosphonates, just very few on other or anabolic or denosumab. Well, you could just think of stopping bone loss, but reverting that bone loss in patients receiving very low dose of glucocorticoids.
Yeah, and you grouped everything together in this analysis, correct? So all the essentially anti-osteoporosis treatments were grouped together. I guess at some point you could slice and dice further of anabolic agents.
No, yeah, that was clearly based on the decision that we have very few patients on teriparatide, just a handful patient on teriparatide with high dose glucocorticoids. So yeah, the vast majority were on bisphosphonate.
Great. And you have a couple of good Kaplan-Meier curves that look at the incidence of fragility fracture, because I guess what really matters is not just the bone mineral density, but actually the fracture outcomes. And you had some really interesting findings, both in terms of cumulative risk of fracture in the patients with rheumatic disease, independent of glucocorticoid use, and then also the relationship between glucocorticoid dose and fracture risk. Tell us what you found.
Yeah, absolutely. I think that the main results here are two. There are two main results. First, you can see that the fracture risk is diverging, so it's higher beyond 2 years of treatment. Please note that those patients were just treated for less than 2 months. So very early users of glucocorticoids. So basically, they just started at baseline and then follow up. So this is not applicable to patients that are continuing glucocorticoids for a long time, very high exposure, cumulative exposure. So let's say you start glucocorticoids. Well, the risk of fracture tends to be higher beyond 2 years of follow-up. So more than 2 years of exposure is probably the worst. And then for very low dose of glucocorticoids, that threshold is postponed even after, probably after 3 to 4 years of exposure. So it certainly is dose response effect, but it's also based on cumulative dose. So the longer you treat a patient with glucocorticoids, the worse it is. And then the second results, to my opinion, really interesting, is that when you look at the fracture reincidence and predicted by the bone mineral density, basically, if you have, let's say, loss in bone mineral density of 3%, you would expect 30 to 40% higher risk in fracture risk. But in patients with more than 5 milligrams per day of glucocorticoids, well, in those patients, they lose 4% of bone mineral density. At follow-up, the fracture risk is 100% higher.
Wow.
Basically, you are not predicting the fracture risk with bone mineral density loss. But there's something else going on there. Probably the microarchitecture we start with the talk with.
Yeah, really interesting. So I'm also interested by the bone turnover markers. And I should have asked you this earlier, but I guess first question, how did you obtain so many bone turnover markers on these patients? And then secondly, you have an excellent graphic of that data too. So could you walk us through it and explain to us how we interpret the CTX data?
Yeah, absolutely. Well, those are a lot of patients, but if you carefully at the data, just a very minor proportion of the whole cohort, because they were not always available. Not all the physicians are doing that. You can enter the data in the data set, but it's not mandatory, even for fracture risk calculation with the DEFRA. So we have less than 300 patients, if I remember correctly. And well, we found that basically with the follow-up, the proportion of patients, please note that those were not taking an antiosteoporotic medication. In that case, the result will be absolutely uninterpretable. But in those who were not taking antiosteoporotic medication, the CTX tend to be lower with the time passing. So this is quite controversial. One of the reviewer of the study argued that it might be that you are decreasing the disease activity. So the disease can become stable and you have lower disease activity, and basically you are treating the osteoporosis. That's the first fault. But on the other side, it might be that it's a low bone turnover state. So in the short term, this has been proven in the literature, you have an increase in CTX, in bone turnover markers, and you have high state bone turnover. Basically, your osteoclasts are working more. They are eating your bones when you're taking glucocorticoids. But then on the long term, as I mentioned before, osteoclast, osteoblast, osteocytes tend to die, tend to work less than that, and you will become in a low bone turnover state. And that might be supported by our results. A higher proportion of patients with low CTX. Well, the numbers were too few. The results were not significant, but at least we might speculate on that, just a few, by saying that, it might be, let's say, at least in line with the previous literature.
Just so as I understand it, the CTX data is really kind of convenience data. So people can, when they're inputting their patient information into the DEFRA, they can add in CTX serum levels if they have it, but omit it if they don't. And so these are not done through a research lab on all of the patients. It's really just convenience of if the data was there, you analyzed.
Absolutely.
Yeah. And I think it's always challenging to interpret bone turnover markers. There's, so many variables that contribute to how those change over time, but definitely useful to analyze and look at that data alongside the other data you present in this manuscript. So you've acknowledged, I think, both in the manuscript and in our discussion today, that there are important strengths of this data and some limitations. So I wanted to give you a chance to talk about those. Obviously, one of the major strengths is that it is true real-world data from cohorts of patients followed longitudinally. Tell us about some of the limitations of this study and the DEFRA dataset in general.
Well, absolutely. Well, the first of all is that with real life data, claim database or cohorts, you might have some type of data that are not adequately captured or are misinserted by the misclassification bias. So basically, we really don't know, and there's no way to do that if there are some errors or systematic errors in the data set. We feel that the samples, the large samples, might have reduced that bias. And the second is that we didn't have access to data on disease activity of those inflammatory rheumatic musculoskeletal diseases. So basically, we might have encountered some type of confounding by indication.
Mm-hmm.
And here is the great debate around, when you are treating a patient with glucocorticoids, you are reducing its inflammation, or you are giving that to a patient with higher disease activity. So there's a great confounding there. But at least we can say that glucocorticoids might serve as a proxy. The causal relationship between glucocorticoids and bone loss, in my personal opinion, is clear. There is a clear dose response, but at least to those who are skeptical, glucocorticoids might serve as a good proxy for starting an antiosterotic medication, at least, because those are a good proxy also for higher disease activity.
Yeah, I think that's fair. And I actually am sort of fascinated by the data you present, because it kind of suggests that perhaps we should consider osteoporosis therapy for rheumatic disease patients receiving lower glucocorticoid doses, which would be a change in practice compared to some of the current published guidelines. I wondered, how are you personally incorporating these findings into your own practice? And how do you recommend clinicians use this data to inform their own practice?
Well, first, I would say that these are somehow contrasting guidelines, but also aligning with very recent guidelines. The ACR guidelines on glucocorticoid-induced osteoporosis that were published just a few days ago are absolutely in line with our results. It suggests that you should start an antiosteoporotic medication in patients with more or equal to 2.5 milligrams of prednisone. So lower than 5 milligrams. So just very low dose, I would say, and with just a moderate risk of fractures. So our cohort was around 13%, 15% of fracture risk, which is absolutely between 10 to 30%, which is the moderate risk factor. So I would say that in this case, it might align. Mm-hmm. We have also proved somehow that the patient below 2.5, from 0 to 2.5 milligrams, tend to lose their bone, tend to have a higher risk of fracture. We certainly cannot isolate the effect of the disease itself on that fracture risk. But as I mentioned few minutes ago, well, this is clearly a proxy for a more severe disease. So it might affect our view of fracture risk in rheumatic musculoskeletal diseases by treating a little bit more those patients with a high disease activity. And please note that in the FRAX, very low dose of glucocorticoids, so below 2.5 milligrams, tend to decrease the fracture risk. So if you adjust the FRAX with doses of less than 2.5 milligrams, you will find that your fracture risk will become a little bit lower, which might be somehow controversial. Why are you taking 2.5 milligrams? You have a longer disease. It is probably not responding to other medication if you are taking 2.5, probably are older, or for whatsoever, it might be not really a good idea to reduce the fracture risk in that patient.
Yeah, interesting data, and I'm sure there is more to come. I definitely want to thank you, Giovanni, for this lovely discussion, and I love how you put all of this data together for us. I wondered if I could walk you down a different path now and talk to you a little bit about your career. Can you tell us about your training in Italy? And then, dare I ask you, how did you find your way to Alabama?
Well, my training in Italy was based in Verona. So I was born and raised in Verona. I studied at the University of Verona in Italy. Here I found my way. And then I have really need to mention that my father was also a rheumatologist and was also researching the bone wood. So when I was early fellow, he clearly suggested me to go to CANSAG, which is clearly an internationally recognized expert in glucocorticoid-induced osteoporosis. So our research interest was clearly aligning, and it was probably the best idea that I had, and was thanked for my father suggesting me. He said he was a great guy, and he surely is. He was a great mentor when I was there. So, yeah, that's why I found my way to Alabama.
And it's actually amazing how many people we've had on this podcast who have at some point in their rheumatology career journey had a period of time in Alabama. So it is exciting to hear that connection. You are a prolific author, and you've many research interests in the field of immune-mediated rheumatic diseases. What particularly attracted you to osteoporosis?
Well, again, I clearly need to mention my father on that. He was my very first mentor. When I started the fellowship, he passed away, fortunately, and he just he never tried to put me on the track on osteoporosis or rheumatology. I did on my choice on that, but he was really passionate about that. He was really passionate about metabolic bone diseases. He always explained me in detail, the calcium handling, renal calcium handling, and so on. And so that's why I chose osteoporosis. And it's also very interesting, disease because it's rheumatological diseases. So everyone is thinking about osteoporosis as a disease of the endocrinologist, but rheumatologists are also the experts of the musculoskeletal system, and the bones bear all the body and the musculoskeletal system. So it's there are a lot of interplays with the immune system. So we are not studying the effects of rheumatic diseases on bone and vice versa. So basically, we are doing a lot of studies on that. So it's there's a lot of opportunities, and also a great influence from my family, from my father.
I love that. I love that you're continuing that legacy through your work. And I think there are a number of rheumatology families actually in the rheumatology world. And maybe that's something that one of our other publications can pick up as a discussion at some point. The other thing I wanted to talk to you about, Giovanni, is you write a lot. You have a huge number of publications. You're still relatively early in your career. So big question, how do you get it all done? Share all your secrets.
Well, I'm really, really lucky because I have great colleagues that helps me a lot. We are doing a lot of works together. So we have a very good group in Verona, my professor Maurizio Rossini, then we have Davide Gatti, another professor, and those are great guys, great mentors, great scientists, and great researchers. So the first secret is having someone that supports you, that gives you the time So you have protected time for research. Then when you have protected time for research and not a very clinical burden, that's easier, more easier. And I don't know, it was practically the same with Dr. Ken Sag in Alabama, in Birmingham, Alabama, because, you have a lot of protected time. I stayed there for just 1 year for the postdoc, and we published like 9 papers in 1 year. So it was great. It was fantastic period. He was really great, responsive on the emails, which is rare for that kind of professor, very, very busy professors. So that was great. And then, well, we have, I know, you have to spend some time at home. So really, 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 the other 6 is to have a very supportive wife with 2 great children that that are great and leaves you the time to sometimes to work even after the time of the clinic.
Yeah. So supportive home environment as well as work environment, it sounds like. Can I ask a follow-up question to that? How do you like to write? Are you, hide in the library with noise cancelling headphones on, or can you write anywhere? What's your style?
Well, not really. Everywhere is fine. Usually, when there are meetings, you have a lot of free times. So basically in congresses or in flights, there are a lot of free times there, or traveling. So that's a very good point to write down or to read a lot of papers. But also, in between patients, when we do clinics, between one patient, sometimes the patient are late or you finish earlier. Well, you have sometimes, I really don't need a quiet environment to read, but it helps, obviously. But it's not. I'm not that type of reader or writer.
Yeah, so you've kind of learned to squeeze it into any available time.
Yeah, also, yeah, absolutely.
Also a key. Giovanni, I want to really thank you. It's been a delight to talk to you today. I'm really appreciative of you sharing your work and sharing your secrets. And I am certain that we will be hearing much more from your team in the years to come.
Thank you. Thank you so much for having me. It was a great pleasure for me.
So today, my thank you goes to the boneheads. Osteoporosis research is tricky. One might even say bone-breaking work with little immediate reward, but it is crucial for our community. Thank you for everything that you do. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org. And rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.